There we go. So turn the cameras off. There we go. Thanks, Nick. Okay, so we'll get started. People will probably start coming on a little bit slowly here, but welcome to our virtual series for June. We're fortunate to have Nicholas Lamphere. He's from our Glens Falls office in New York, and Carly Rosenberg, who's from our Saratoga office. Both of them are part of the sports SIG and have worked hard on an ankle instability presentation. This is going to pair well with a presentation we had earlier from a physician at our lunch and learn. So we're trying to have some of these matching physician perspective and therapist perspectives as we're moving forward with some of our virtual series, and use that as a launch pad for improving some of our outcomes with our patients with some of these challenging conditions. So they've put a lot of work into this, so I am just going to let them go ahead, and I want to express gratitude, because to do a presentation and to get it prepared, it takes a lot of work. So thank you to you both, and I'll hand the floor over to you.
Perfect. Thanks, Terry. Let me just share my screen again because it kicked me off here. We're good. We can see it.
Yes.
All right. Perfect. All right. So as Terry said, we did a kind of lunch and learn / sports SIG project for advances in ankle instability with a focus on returning to sport. Click to the next one here. So quick learning objectives for today. 1, review and understand common ankle injuries in athletes. 2, understand activity progression through initial rehab to return to play, milestones important to symbolize progression. 3, discuss the factors that play a role in determining if an athlete is ready to return to play, and then the return to play testing itself. So just the ones we're going to focus on here, obviously there's a ton of different ankle, foot, lower extremity injuries that we could have discussed, but we decided to focus on lateral ankle sprain and syndesmotic or high ankle sprain, as well as the brostrum and modified brostrum repair, just because these are the ones we're going to see most consistently in our clinics that kind of across the entire company. So lateral and high ankle sprains, a lot of the research that I found kind of led me to the same kind of progression and rehab protocol. So I kind of just lumped them together. But I just wanted to note that there can be like a 7 to 10 day difference in the rehab. So just use the resources you feel like you need to if there's a little bit of a discrepancy. But 0 to 2 weeks, just going to be working on any pain-free range of motion. So we don't really want to irritate the tissue, but rather just continue to move within a range that the patient is comfortable with. Promoting proper gait as soon as possible. This starts, right at the initial eval, trying to get them to walk as properly as they can. And then low intensity activities, pretty much just walking based on the research multiple times a day to help load the tissue and kind of stimulate the healing process. 3 to 6 weeks, really getting aggressive, kind of going after the dorsiflexion range of motion as quickly as possible, especially if it's significantly limited due to the injury. Working through your graded mobilizations, starting with grade 1 and 2 for pain modulation, and then getting into 3 and 4 for more range of motion and mobility. Just some basic couple things to get started with. Obviously, the 4-way ankle strengthening with the TheraBand, easy to do in the clinic, easy to do at home if the patient has TheraBand available to them. And then beginning a heel raise as soon as they can do it pain-free, starting with double leg and then moving into single legs whenever you feel like they're ready to do so. And then at the 7 to 11 week mark, so this just marks kind of the duration in which they're getting ready to do sport activities, but not ready to actually return to the field. So initiating closed chain lower extremity strengthening, such as squats, step downs, step ups, you name it, anything that's weight bearing. Then beginning the plyometric activity, starting with hopping, small hops, starting with agility. Usually, basic one is the agility ladder. Then getting into small hops with short distance and low force production, building up the distance and the force, and then getting into bounding where you're more pushing off of that single limb. to begin to really load the tissue in that single limb support. And then I just like to point out, I don't know if everybody has access to it or if it is on the intranet, but the return to running protocol that MVPT has. I know we have a bunch of copies here in our Glens Falls and Saratoga offices. Just handing this to the patient and helping them kind of work through that protocol to say, this is how I want you to kind of start running. It's 1 minute on, 1 minute off, builds up to 2 minutes on, and it has all the dates and weeks in which they should progress. And you can modify that as needed for the athlete. And then 12 weeks to discharge. This is all just return to sport testing. So single leg hops, bounding, agility, working on change of direction. Obviously, lacrosse, basketball, soccer, things like that are going to be a lot of lateral cutting. If you're someone working with someone who's a runner, that's going to be a lot different. You're not going to have a ton of change of direction. So the change of direction training, while still important, might not be your main focus. You might think more power. And then all activities, again, like I said, should be geared towards that sport specific loading to really make sure they're ready to return to the field before you clear them. And then this is a framework that I found. It came up a couple times, but it was originated in 2021 in the British Sports Journal. So the PASS framework, standing for pain severity, ankle impairments, athlete perception, sensory motor control, and sport performance. So pain severity during sports, and that's when they're actually competing in their practice themselves. So you'd have them go through a whole practice, and then they come and see you at your next appointment, and you'd be able to talk to them about it. Obviously, you don't want them to have any pain during their practice, but it did say that you could go up to a 2 out of 10 on the patient's subjective scale to feel comfortable enough to pass them there. Ankle impairments, these are just your general objective measures, mostly strength and range of motion. If you have ways to measure power, you can do that. Endurance, you can use this single leg calf raise test. But really, strength and range of motion were the big points there. The athlete's perception, which we have some forms and outcomes we'll talk about later that can measure confidence and psychological readiness. And I'll talk about the FAM a little bit later as well. But that's another good outcome measure that's going to talk about confidence and readiness to return to daily and sport activities. Sensory motor control, it's really just fancy way of saying balance. So just testing single leg balance, narrow base of support, balance with dynamic activities. And then the sports performance themselves with their hopping, jumping, agility, which speaks more about the return to sport testing. But this can just be general hopping, jumping, agility. How do they perform doing these activities? And when you recreate a sport specific activity in the clinic, how are they performing it, as well as what are they feeling and how comfortable are they with that activity? And then this tool here, I really like this tool. It's the Cumberland Ankle Instability tool, and this measures strictly function. So this has absolutely nothing to do with sports itself, but this is more of kind of like almost ADLs, if you want to think about it that way. So I put the form here, and I do have a Word document with the link to the actual scoring sheet, so I can send that to Terry to send out to everybody, or I can send it out. But this is measuring how they feel with these activities on a scale of 0 to 5, 0 to 4, 0 to 3, with a score of 25 or less, indicating chronic ankle instability, meaning they did not pass and will need to continue therapy. 26 to 27. Some articles said 26 was still counting as ankle instability. Some saying 27 counted as good. So they kind of put this where they just said overarching clinical judgment would be necessary in this case. But most of the researchers said that they still would not feel comfortable at this time if they scored these 27 or less to say that they truly believe they are ready to begin returning to sports. And then 28 or higher, which it's only out of 30, means that they have a functionally stable ankle with minimal perceived instability, and they would be ready to return to that next step to get back into sports. And then just wanted to point out it does have a high reliability, and its test retest is 0.96 with good sensitivity and specificity. So it is a really good outcome measure. Obviously, none are perfect, but I think this puts a better focus on strictly the ankle rather than the LEFS, which focuses on the entire lower extremity with some activities that may be a little more irrelevant for our athletic population as a whole.
All right, so I'm gonna take over and we'll go into a little bit more of the surgical management. So like Terry said, we had a really great presentation by Dr. Hoffman, and he went over kind of like the current practices for the brostrom repair and the modified brostrom, and a couple of the like new kind of higher tech stuff that they're doing, like the internal bracing and things like that. So that was a really great talk if you guys want to go back and listen to that one. But kind of starting off here, one of the things we found was that the chronic side of ankle instability is lasting in about 20% of chronic ankle sprains, which leads to just like a kind of mechanically unstable ankle. So that's where the brostrom comes in. It just kind of does an anatomical repair of the ligaments that have kind of stretched over time. The ATFL and the CFL are the main ones. And then, if you want to go to the next slide, Nick. So the first one would be like the modified brostrom. It's really just kind of cleaning things up, using a little bit of the extensor retinaculum to stretch over and kind of reinforce. And then the other protocols I looked at also went into the brostrom Evans procedure, which is the same. It just uses a little bit more of the peroneus brevis to kind of thread through and reinforce again. And then, so obviously every protocol is different and definitely important to follow what your physician's guidelines are. Definitely different locally for a lot of people, but we usually find with ours around here that they're usually kind of like lacking information. It's just kind of like phase 1, phase 2, phase 3, not very specific stuff. So thought we'd go through that a little bit here. So typically the first couple of weeks you're avoiding any active or passive inversion, eversion, or plantar flexion, just to kind of protect the grafts and make sure everything is healing in the way it should. And then you can start the little bit of like intrinsic stuff, so like toe yoga, doming, splaying, marbles, things like that. They're usually pretty frustrating in the beginning for people, but they figure out pretty quick that they're actually kind of hard. And then the 2 to 6 weeks is when they'll probably start to be in a walking boot, a little bit of toe touch weight bearing, still pretty limited on the range of motion. Actively and passively, we're avoiding inversion still. And then this is where we start to hit some of those milestones. So kind of looking at the milestone instead of the weekly timeline to progress from here on out. So greater than 75% passive range of motion of the uninvolved side would be the kind of the step off point to move on to the next one. And then the return to function. We're still avoiding active inversion and passive range of motion until week 9, typically. I don't think I mentioned this in the beginning. I kind of married 2 protocols together to make this. So I was looking mostly at the Ohio State brostrom repair for modified brostrom and the Brigham Women's. So both from those protocols is where I got this stuff. So both of those are good resources. And then this is where we're kind of progressing weight bearing, kind of loading the tissues, starting a little bit of balance within that precaution guideline. And then again, this is another milestone. So we're looking to get strength within 90%. So this is usually typically a longer phase for people because the kind of the standard here is to get those 25 single leg heel raises for return to run. And I said this in the sports seg too, but we all have our own kind of like return to run screen. But kind of that's kind of a baseline one, especially for an ankle surgery. But then looking kind of up the chain too and making sure things like single leg squats and all of that can kind of clear them to return to jogging. And then next we would be into that 12-week-ish phase. And that would be straight plain jogging without pain. And that's when you can start kind of, like Nick said, that return to run protocol. And then the next slide, Nick will talk a little bit more about this later, but if you want to go to the next slide, Nick.
Mm-hmm.
So this is just kind of like functional hop testing. We have a sheet in the Saratoga clinic that we use. It's probably the same in Glennsville. That is just kind of like slated out all of these tests, and we have a right side, left side, and you know which one is the unaffected leg and the affected leg. And then it just kind of like walks you through doing the percentages. So it's all these tests on there. All of these are great for kind of like, especially even just helping the patient to realize where the deficits are. Sometimes when you get somebody back to jogging, they feel invincible. So these are good ones to kind of demonstrate that there can be a discrepancy still. And then we'll do the STAR excursion test. Thank you. So this is another really good return to sport test for the ankle specifically, but also just like any kind of general balance. So like ACL or anything too. This could be a helpful one, but this is just going all 8 directions on both feet. Can be kind of a tedious test because you have to measure in every direction, but it can really show the difference between like which angles would be more difficult for the patient, especially depending on their sport. Couple things to avoid here is like, or that would like invalidate the test, I suppose, would be like any toe touching down, obviously using anything to hold on to for balance. The patient's hand should be on their hips the whole time. And then when they do reach with their toe, it should be a really light touch. Anything like heavy, like putting weight through the foot would invalidate it. Most people would measure this just by doing the average distance in each direction. So 3 trials added together and divided by 3. Some people do the percentage, which would be the average distance divided by leg length, which is just kind of like another step. I'm not sure how much more information that would give you, but if you're a math person, that might be fun. But so yeah, that's the STAR excursion. So I think Nick has some more jumping stuff to look at.
So I just kind of threw up a couple of pictures from one of the resources that we kind of pulled from. And this resource is nice because it has a scoring sheet as well as a description of the test. So I just wanted to point out the 4 main ones that seem to be the most researched backed. All the ones that Carly talked about have been mentioned in research. And like she said, MVPT/Baystate does have the testing sheet that I feel like you should be able to find on the internet. But this is the one that the research talked about the most. So the figure 8 hop test is a single leg hopping test that is timed. Cones are placed 5 meters apart and you have them figure 8 around. It doesn't matter which side of the cone they necessarily start on, but the set standard that they just mentioned in the test is having them start on the right side if they're using their right foot, on the left side if they're using their left foot. But if you start opposite, it doesn't invalidate the test as long as they complete the figure 8. The 6-meter crossover hop test. This one specifically states 15 centimeters for the line. This is the only resource that mentioned an exact distance. The rest just said that the foot needed to completely clear the line, and they have to complete the 6-meter distance. So I wouldn't be too concerned if you have a tape line or something you lay down on the floor in the clinic and it's not quite 15 centimeters wide or it's a little bigger. It might just be something to note for your test so you can retest it appropriately. The side hop test, I'll show you the specifics of this, but this one, they all do state 30 centimeters apart, and the foot doesn't need to land line to line. It needs to clear the line. If they do not clear the line, the test would then stop, and you would just count the number of reps that they completed before they could no longer jump all the way across. And then the dorsiflexion lunge test is actually not something that I've heard about until I started doing the research for this project. So you actually measure based on the distance from the wall to their big toe. And I believe it says anything between 9 and 10 centimeters or less is passing. Anything over 10 centimeters away from the wall would be considered a fail. And then obviously you want them to make sure they're at 95% compared to the uninvolved lower extremity. And then just to point out the single leg calf raise test, like Carly mentioned, we use the 25 single leg calf raises as one of the landmarks for return to running. But you want to make sure, it doesn't necessarily need to be 100% 25 based on the research I found, just making sure that If the uninvolved side can do 18, the involved lower extremity can do at least 95% of whatever number that is. And then the vertical hop test, this one I wanted to point out just because it is there. I think it's going to be harder for us and a lot of our clinics to test because in the research, they used a force plate. But I did see an alternative method of scoring is using, if you have a clinic smart device, or if you have the patient use their phone, you can take a video in slow motion and then test how high up in the air they go. I know it's not the most accurate way to test it, but it is a way to test. But I did want to mention that as an option. And then I will pull up the scoring sheet as well as the test just so you guys can see. Can everybody see this? So this is just a quick scoring sheet, and this is printable, obviously showing right, left, and then you can do the math as to percent different, pointing out the wide balance, single limb heel raise, dorsiflexion lunge, single limb vertical jump for distance, figure 8 hop, and then the 6 meter crossover and the side hop. And it has all of the directions here with how to set up the test, as well as what a failed versus a passed test is and how many times to record the trial. This does show a t-test on here. I think this would be pretty hard to set up in a lot of our clinics, and this is the only resource I found that does mention the t-test as an option. So I don't think it's necessarily the most valid test or the easiest thing to set up and collect data on. So sticking with the other tests that are mentioned in multiple research articles is perfectly okay. And I think that's kind of how we built as a company the outcome and testing that we use. So going back to the outcomes we talked about, I'll just go to the PASS framework quick. Obviously, I talked about that already, so I won't go back over it. The foot and ankle ability measure, this is kind of like a more specific LEFS in a way. So this is going to be similar to the ACL confidence scale and how confident the athlete or patient feels in returning to their sport. And I will send the link to this to Terry to share with everybody, because this is a really good tool that I think I'm going to start implementing into my post-op ankle patients, as well as the ankle instability and lateral ankle sprain patients for return to sport, because it gives you a really good idea of what athletic abilities / movements that they perceive they're going to do well with and what they perceive they are not going to do well with. And then the fear avoidance belief questionnaire. I don't know if most people know, or some people don't, but it was originally designed as a low back / spinal questionnaire. And there's actually an adapted version that now talks specifically about the ankle and how much fear a person would have in doing certain activities involving the lower extremity. So the questions are a little different than the standard test, but they have adapted it to be strictly an ankle questionnaire as well, which I also have the link for that I will send to Terry. And then we have the LEFs that we use here. It's a good outcome, obviously, to get data. But as you guys know, I'm sure your patients have said, well, I don't do this or I don't do that. And it's not the most athletic / sports specific questionnaire in the world. So it is good to get data, but I don't think it really paints a phenomenal picture. So using something like the FAM, the FABQ for the ankle, or the PASS framework, I think gives you as a clinician a much better understanding, as well as more data to make a good clinical judgment with your patient to decide if they are truly ready to return back to the field, court, whatever sport they're playing. And then these are just our references here of everything in case people wanted to take a look at kind of where we found all of our information. So now if anybody has any questions, feel free just to raise your hand. Terry can kind of monitor that and then ask away.
One thing I wanted to mention that I forgot to say earlier, we talked about this in the sports seg. Somebody asked a question that all return to sport testing should be done without a brace, just because that's kind of going to give us the best look at how they're doing compared to the other side.
Excellent. Well, oh, there's already a question.
Hi, I'm Duan. I'm currently my last clinical rotation right now. So I have a question for the like the timeline, because at the beginning you guys said it's depend on the phase. There's a 10 days difference. So I want to ask for special acute phase. If you want to look at that symmetry for the passive range of motion, and we look at dorsiflexion and most of the time, or like, because we cannot do active inversion and passive range of motion for inversion as well. So should we got every rest direction matched up to that 75%, move on to next step, or it's just more like a genuine idea about looks like we're close to
Yeah,
next
so
step.
I'll speak on the ankle instability stuff, and then Carly can mention, kind of clarify with the surgical stuff. But I was mentioning the 7 to 10 day difference in timeline because one, the resources are all just a little different based on which protocols, research articles, whatever you may use. But typically, high ankle sprains are going to be a little bit more severe. They just tend to cause a little bit more pain. So the 7 to 10 day difference usually comes with, if anything, the ankle sprain is going to slow it just it's going to heal at a little bit of a slower rate.
Okay, so that gonna be my following question. So if there's one patient come with high ankle sprain, like for week 1, this patient says, I feel much better, and they already got the nice passive range of motion, or like match to like over 75 of the good side. Should we just start doing more like a closed chain, like a body weight loading exercises, or we should focus on like we still put that at week 3?
Yeah, I
If
think you
my
want to make
question makes
sure that
sense.
they have as close to full range of motion as possible. I mean, I think if dorsiflexion in particular, I found personally that a lot of people don't have great dorsiflexion. So you definitely want it to equal the other side or be within probably 90%. I think 75 is still a little low. Get it within 90% of the good side. And then as you start to do closed chain exercises, which at that point I think it'd be appropriate as long as their pain level is minimal to none, to move into that closed chain strengthening, which is also going to help squat step downs increase that dorsiflexion range of motion. So some of it is going to be clinical judgment, like with most cases and patients, because everybody is just a little different. But you want to make sure that you go after the range of motion and make sure you're as close to even on both sides, particularly with the ankle sprains, but especially with the surgical side, because surgeries you can get a little bit more behind in a protocol / healing sense. But with the Brostrom, and Carly can add anything necessary, Brostrom and modified Brostrom, they can be a little bit tricky in the fact that they can be a little sensitive to movements. So those timelines, from what I kind of looked through, and I didn't look through as much as Carly did because she was kind of focused more on that. You kind of have to let the healing process work its way through. You're never going to truly beat the biology in the sense that the healing is going to take time. So that might be a little more strict, but with the ankle sprains, ankle instability, things like that, it's a little bit more lenient based on patient subjective feelings as well as the objective data you may collect along the way.
Thank you so much.
Eileen, wondering about, I came in a few minutes late, so maybe I missed this, but I'm wondering about isometric strengthening after the ankle sprain in the early weeks and also after the repairs.
Isometrics can, and I didn't necessarily touch on this just so I wasn't going down the rabbit hole of every exercise. When the patient's pain is in a level where they can tolerate isometric strengthening, you can begin. So it can be as early as week 1, week 2. But that is more subjective. Usually they're going to be ready week 3, week 4 to start with TheraBand. So usually in the week 1 or 2 timeframe, as long as the patient can tolerate, you can begin the isometrics.
And when you're talking about TheraBand, you mean with the range of motion? Are you talking about TheraBand with isometrics?
So TheraBand, thinking more concentrically, so doing active plantar flexion, inversion, eversion. I know Carly can mention the Brostrom stuff because that's going to be a little different with the timeline for the isometric stuff.
Yeah, so for the Brostrom, it does, most of them said submaximal ankle isometrics at like 2 to 6 weeks mark. So just again, like kind of paying attention to the pain level and making sure that it's tolerable. I think a lot of times with isometrics, you have to remind patients to do it submaximally. So just kind of giving them a little bit of that heads up too, as because there might be a little bit of pain involved with a maximal isometric.
Thank you.
Do you guys, great presentation. Thank you so much, by the way. And just a question, when you're doing the return to sport testing, do you gear some of the different testing per the sport that person's involved in? Basketball versus soccer or runner, or do you just go through the battery just regardless because they're going to have to challenge their ankle in all those ways anyway?
At least for me, I usually keep to the battery just to keep it kind of like standardized. Far as like the specific testing, but then like adding in like in the clinic stuff for like sport specific. So not necessarily the testing, because a lot of this stuff is like researched and kind of demonstrates stuff over time, but then kind of going into like those sport specific movements like per the person that you're working with.
Excellent.
I don't think it's a bad idea though. What I've done sometimes with some of the ACL stuff, even since we see that a little more often, is I've actually used some of the testing that's not in our standardized treatments as the standardized outcome as treatment. So just because it's a test doesn't mean you can't use it as a treatment. So if it's not something we necessarily test, doesn't mean we can't use it. So like you said, we listed so many different tests and we're not going to be able to run through all those. It would take an hour and a half to get through all that testing in a session. But you can definitely use those as treatment activities for all the change of direction, but try to make it a little fun, obviously, in here too. So if you can make something really sport specific, like we've had people in our clinic with, we had to bring her basketball in. We've had people bring soccer balls, things like that. So incorporating what they're going to be doing the best we can in the clinic is obviously going to be the best way because that's going to make it as natural as possible for them.
Excellent. Thank you. And for the STAR, what if for the people who don't have, do you guys have the STAR official out of the box kind of measuring tool, or do you have a workaround that you can recommend for people?
No, I can't say honestly that I've done it super frequently. But like when I've done it in the past, it's just putting tape on the floor, and just kind of like, it's a straight line when you tape it down. So, and it's pretty easy, just cross and then it's one each way. So
that's what we do at our clinic. So I was just curious if there was any other recommendations out there. Let's see, did I have another? Okay, does anyone else have any other questions? Quiet group tonight. Maybe they're watching the Brazil-Scotland game that's going on right now. I don't know. So we went to Boston to celebrate with some of the Scots on Friday. That was kind of fun. But I digress. Oh, there we go. Oh, thank you. So yes, just a thank you in the comments there. So what I'm going to do is, for those of you who are internal to the company, there will be a recording of this, and eventually I'm going to put it on HealthStream and match it with Dr. Hoffman's presentation. So then it'll be like a intensive ankle presentation that'll be a great package deal. For those of you outside of the company, this will be recorded and available for you as well. But I do want to thank Carly and Nick for taking the time to do this. I hope everyone has a wonderful evening, and we'll see you at the next virtual series. We're going to be covering the temporomandibular joint next month, so stay tuned. So thanks, everyone.
Thank you so much. That was great.
Thank you. That was amazing.